Thank you for meeting with me today. I just want you to know the purpose of this survey tool is to gather information to facilitate a thorough analysis of what happened with the Torres family. I am going to be referring to these questions as we conduct this. I want you to know that this is part of a debriefing process, but the information that you shared will be confidential. Your responses to these questions are not going to be used to assign blame. The purpose of this tool really is to get at factors that may have contributed to the adverse events with the Torres family, but any information you share will be confidential and will be destroyed. So when we collect data, it's only going to be in an aggregated, de-identified manner. So I did want to assure you of your confidentiality. As a manager, it's going to be important that you provide an accurate, unbiased account of what happened. We're asking especially that you look at this from a systems level perspective. So as we talk about this, be thinking about things that may have contributed to this event that perhaps occurred at a system level rather than an individual nurse-patient level. In providing this information, please be as informative, as specific as possible. We're really using this information only to gather data that can help us look at system-level factors that may have contributed to it. And again, I do want to assure you that everything you share will be confidential and de-identified. I want to talk a little bit about communication factors that may have led to this event. Tell me a bit about communication between the nursing staff and the medical staff, or any breakdown in communication process that you think may have occurred.
You know, on this particular night, my concern was we had just gotten, we hit the reset button. We have new residents that start in July, and this happened in late August, early September. So it's a new group of providers that aren't comfortable with the way that we would like to teach our nurses and physicians to communicate. There could have been better communication between the first-year resident and the nurse in this case, and I feel like that's something that we're going to have to take a look at in the future to get those residents involved a little bit earlier in the process. As far as my nursing staff, I believe they did as much communication as they could with each other. Certainly the nurse involved did all that she could to reach out to get help from her colleagues and from physicians alike. And unfortunate that it was at a time when there were several emergent situations going on. We had 3 patients on Pitocin. We had a C-section that was about to start, and then this delivery that was going on. So it's part of our culture to really make sure that everybody knows what's going on at the time. So if we have to make any mid-course adjustments, we can do that as quickly and as seamlessly as we can.
Talk to me a little about the chain of command and how you would expect staff to escalate issues when there's a lack of response or unclear lines of authority.
We do have a chain of command. I'm not convinced or confident that all of the staff are aware of it or use it appropriately. I do feel like a lot of times situations will come up and you feel like, oh, if we can just get through this next 10 or 15 minutes, we'll be fine, so I don't want to set those wheels in motion. And again, we're working on it. The chain of command is there for a reason. It's there to help you get resources quickly if you need them. And again, it's something that we have our staff go through an orientation. We have a skill that we practice with in the simulation lab that uses that. We do a postpartum hemorrhage emergent OB case in our simulation lab, and we use that. So it's a tool that's available for them, but my concern is that I don't know that they all know how to use it or what the order is.
Were you staffed appropriately that night? Tell me a little bit about your staffing patterns.
I was actually a little worried about this night. It was a holiday weekend, and we knew that we had some holes in our staffing areas In fact, they called me in at home, so I came in and was working side by side with them. So yes, there were some staffing holes that night. We didn't have quite the team that we needed, and our secretary had been floated to another unit. We couldn't get her back, so a lot of the paperwork that had to be pulled was being done by nursing staff, which in a lot of these situations isn't ideal. But again, the nature of the business, and you just do the best you can.
Tell me a little bit about your orientation. Do you feel like all the staff that were involved had the opportunity to participate in simulated drills? For example, do they have a drill on shoulder dystocia?
We do not do a shoulder dystocia drill. We have just started these drills. We've been doing them about 18 months, and the scenario that happens, probably the most common, is postpartum hemorrhage, so we elected to start with that. We certainly have shoulder dystocia on our list of drills that we want to do, but we had not set up that scenario at this time. All of my nurses are required to be fetal monitor certified, and in addition, we're working towards them getting certified in their specialty, their RNC, and with that comes a lot of knowledge about how to handle shoulder dystocia and what to do in that event. So we hope to build that into a drill later on, probably at the end of the year.
Talk to me a little bit about the culture on the unit. How do staff relate to one another? And how do you think the nursing staff and the medical staff communicate with each other?
I know, because I've been told by several of my staff, that we have some cliques on the unit, and we're in the process of trying to address that. We've had some retreats and talked about that, and as a whole, we want to have a culture where it's safe to speak up, and we want to have a culture where it's safe to reach out and know that someone's going to help you. Speaking up, for example, in this case, the nurse she knew what to do. She knew that this resident needed to try some other maneuvers, but she didn't want to embarrass him, so she didn't say anything. What we want to get past is exactly that for the good of the patient, for a better outcome, we owe it to patients to speak up if there's a safety issue, and to initiate the chain of command in the event that something is escalated or you do speak up and nothing happens. So it's something that we're working towards as a unit, and it's certainly something that I think will keep patients safer if everyone owns some of that.